Our next abstract is 843, high lung attenuation measured with quantitative densitometry as a surrogate marker for interstitial lung disease in RA, association with anti-CCP, smoking, and absence of shared epitope. Will be presented by Dr. Mikhail Alevizos.
Thank you. On behalf of my co-authors, I would like to thank the selection committee for the opportunity to present our work on assessing predictors of RA-ILD using quantitative lung densitometry. We have no disclosures. ILD is a major source of morbidity and mortality in RA. About 8 to 10% of RA patients will develop clinically significant ILD over the disease course, and the average survival is only 6.6 years after diagnosis for these patients. However, many more RA patients do exhibit subclinical ILD on imaging, and this can occur in up to 50% of them. Despite this prevalence, the pathogenesis of RA-ILD is poorly understood. Adding to this complexity, there is significant inter-observer and intra-observer variability in the detection of ILD by radiologists, which makes it more difficult to study the disease. Quantitative lung densitometry is a novel technique used in ILD research that utilizes a computerized algorithm to measure the density of the lung parenchyma. It's thought to be more accurate than the human eye, especially when assessing subclinical mild ILD. High attenuation areas, abbreviated as HAA, which are measured by quantitative lung densitometry, are a surrogate marker for ILD. Therefore, calculating the percentage of parenchyma with HAA determines the extent of ILD on densitometry. Based on previous studies, HAA affecting at least 10% of the parenchyma correlates with restrictive lung physiology and increased probability for interstitial abnormalities on visual estimation by radiologists. No studies to date have used quantitative lung densitometry to assess predictors of RA-ILD. Therefore, we sought to identify risk factors, both demographic and RA-specific, for high baseline HAA and HAA progression. The population study was made up of RA patients enrolled in the ESCAPE RA cohort, which is a prospective cohort study of subclinical cardiovascular disease. Included participants were between the ages of 45 and 84. They fulfilled classification criteria for RA, and they didn't have any prior cardiovascular events and procedures. At baseline visit 1, patients underwent cardiac CT scans. At visit 2, at 21 months after baseline, they underwent pulmonary function tests and they completed pulmonary symptom questionnaire. Lastly, at visit 3, they had repeat cardiac CT scans. We explored lung structure using a variety of modalities. Patients underwent a 64 detector CT. Lung parenchyma from the level of carina to the lung basis was included, but not the apical lung fields. The lung fields of cardiac CT scans were assessed with quantitative densitometry with the use of specific software. Similar to prior studies, a voxel was considered indicative of ILD when the assigned density by the software fell in the range of -250 to -640 Hounsfield units. Then we calculated the percentage of HAA, of high attenuation areas, using this formula here, the number of voxels in the ILD range divided by the total number of voxels multiplied by 100. And this percentage of HAA reflects the extent of parenchyma involved with ILD. Also, an experienced pulmonary radiologist evaluated each scan of the baseline visit for ILD features and calculated a semi-quantitative score based on the presence and extent of ILD features, and the score range was from 0 to 32 points. In terms of statistical analysis, we first tested in univariate models each of the demographic and RA-specific characteristics against our two outcomes. The first outcome was high baseline HAA, affecting at least 10% of the parenchyma, and the second outcome was HAA progression in the follow-up period, defined as increased by at least 10% from the baseline HAA. The associated variables were then carried into multivariable models. And for our results, a total of 193 patients were included. The mean age was 59 years. The median disease duration was 8 years, and the majority of patients were women, Caucasians, seropositive for rheumatoid factor CCP. They were on DMARS, and 35% of those had, and 35% of the cohort had ILD on extra DRID, predominantly mild. 8% of the total cohort had restrictive pulmonary physiology on PFTs. Compared to those with limited involvement with HAA, those with more extensive involvement had significantly higher BMI, lower FVC, higher ILD score on extra DRID, and greater proportion of them had restrictive pulmonary physiology. In univariate analysis, BMI, rheumatoid factor, anti-CCP titer, log CRP were positively associated with high baseline HAA. After carrying significant and near significant variables into an extended and then a reduced model, we found that female sex, pack years of smoking, BMI, CCP units in the highest decile were each associated with the outcome of high baseline HAA. The area under the curve for the final multivariable model to predict high baseline HAA was pretty high, 0.89. Of the 193 patients who had densitometry at baseline, 107 patients had repeat densitometry in 39 months after baseline. In 39% of them, the extent of HAA progressed. The group of patients with repeat densitometry had slightly lower rheumatoid factor and CCP titers compared to those who didn't. Otherwise, there were no other demographic, RA-specific, or treatment differences between the two groups. In univariate analysis, the shared epitope was negatively associated with HAA progression. There was also a trend towards significance of pack years of smoking, CCP units, log CRP, and log baseline HAA. In the final multivariable model, CCP units were positively associated with HAA progression, while the shared epitope retained its negative association with the outcome of HAA progression, interestingly. This is essentially the same information presented in graphs. On the graph on the left, the group whose CCP titer fell into the highest tertile had a 53% adjusted probability of HAA progression compared to 28% for the group of patients whose CCP fell into the lowest tertile. And this difference was statistically significant. On the other hand, on the graph on the right, shared epitope positive patients had 30% adjusted probability of HAA progression versus 60% for the shared epitope negative patients. Then we looked to see if there was any differing effect of the shared epitope with the black circle here on the CCP strata split in the median here. And the protective effect of the shared epitope was numerically present in both strata, but statistically significant only in the low CCP quantile. So in conclusion, among RA patients with mild subclinical ILD, smoking, anti-CCP, BMI, and female sex were each associated with high HAA at baseline, which is a surrogate marker for ILD on lung densitometry. The high HAA observed in obese patients and women may not necessarily reflect ILD, but may be related to atelectasis or increased soft tissue present in these patients. Among RA patients with repeat lung densitometry, anti-CCP was positively associated with HAA progression, while the shared epitope exhibited a protective role against it. Similar negative association between the shared epitope and RA-ILD was also observed in a previous Japanese RA cohort study. There are several strengths and limitations to mention. This is the first prospective cohort study to detect RA-ILD using lung densitometry. And the advantage of this technique is implied by its name. It's quantitative, it's operator independent, it's easily applied to standard clinical CT scans. And another strength is the focus of the study, which is the subclinical ILD. Among the limitations, the lung parenchyma analyzed here on cardiac CTs did not include the apices. However, good correlation has been shown between cardiac CTs and dedicated chest CTs when it comes to HAA evaluation. Patients here generally had mild ILD, so risk factors that the risk factors that we identified may not be predictors of more rapid severe ILD. And finally, a smaller group of patients had repeat densitometry in the follow-up period. There are several implications. Risk factors such as smoking, anti-CCP, and absence of SERT epitope could identify RA patients at risk so they can undergo further screening for ILD. This study provides further insight into the different genetic background of articular disease versus ILD in RA. While the SERT epitope is the strongest risk factor, genetic risk factor for the articular disease, it did protect against RA-ILD in our study and in a previous study. Similarly, MAC5B was recently recognized as the strongest risk factor for RA-ILD, but MAC5B did not correlate with pure RA whatsoever. Finally, quantitative lung densitometry could represent an important tool for clinical trials to assess outcomes, and this will require further validation in future studies. I would like to thank my mentors and colleagues at the Division of Rheumatology at Columbia University, where I was able to pursue this research. And thank you all for your attention. I'm happy to take questions.
This abstract is open for questions.
Can you comment on the how you derived the clinical significance of greater than 10% progression of HAA? Where does that number come from?
There is some published data that a baseline HAA affecting more than 10% of the parenchyma does correlate with restricted pulmonary physiology and does also correlate with interstitial abnormalities on visual estimation by radiology. So we use this published data on that.
If there are no other questions, thank you very much.